Hello, my name is Dr. Richard Aline and I'm a palliative medicine consultant, and I want to just talk to you briefly about having conversations about resuscitation. So I think the very first thing to say is that this is not a choice for the patient. Okay, so what you're not going in this conversation to do is work out whether the patient would like to be resuscitated or not. In fact, if you ask them that question and say, would you want to be resuscitated, that is the wrong question to ask, and I would really hope that you don't ask that question. What you're trying to do is communicate your medical decision, in your medical judgment. In your judgment, do you think that resuscitation is going to be successful or not for this patient? I don't really talk about futility, because that's a value judgment. You're making a decision. You're saying, I do not believe that resuscitation is going to be successful for you, and now you're trying to communicate that. The second thing I would say is that the best way to talk about resuscitation is to not talk about resuscitation. And what do I mean by that? I mean that resuscitation by nature is in the negative. It's what we're not going to do. It's essentially a treatment that's going to be withheld, and you can imagine some patients feeling that if you present it in a way, oh, so you're not going to give me this treatment then. So what I like to do, and I find effective, is reframing the conversation in the positive. So talking about what we are going to do when that patient reaches the end of their life, the things that we can achieve, how we can make them comfortable, how we can manage their symptoms. So the second point is reframe the conversation in the positive, talk about the things that we can do. The third point is about the type of language that we use. It's really important not to be vague. So as doctors, we don't like talking about death and dying, and we like to skirt around the subject if possible. If you die, of course the patient is going to die, and that's the reason we're even there having the conversation. So let's talk about when you come to the end of your life, or when you die. Let's be clear so that patients aren't left feeling that I wasn't quite clear what that doctor was talking about. So the fourth point is really about how we broach the conversation. Now, what I will have done coming into the conversation is obviously ask them how they are, and try to understand their context and their condition, and have they been deteriorating, and all of those kind of things. So I've done my kind of assessment, but at some point I need to start talking about the resuscitation aspect of this. And to bring it up, what I'm going to do is ask them this key question, which is, where do you want to be cared for when you come to the end of your life? That to me is a very powerful, very simple question, which patients will, the vast majority of time, know their answer to. And most patients will say, I want to die in my care home, I want to die at my home. They'll have a good idea when you ask them that question. And what they're doing by telling you that they want to die at home, indirectly they're telling you that they don't want to be resuscitated. They just don't quite know that they're going to say that yet. You're going to help them understand that that's what they actually do want. So you've broached the conversation, you've asked them where they want to die, and the fifth point then is to try and expand that, try and understand that in more detail. Because this is the essence of this conversation, really. It's understanding what's important to that patient, and you might want to then explore what's important to you. So when you do come to the end of your life, have you told your wishes to anybody that's important to you? Who is important to you? Who would you like to be with you? Have you got any fears about what it's going to be like, or any worries? And what's good about that question is that if they say something like, I'm frightened of being in pain, I'm frightened of being alone, you can use this opportunity to dispel that fear or address that worry that they've got. If they said, I'm scared of being in pain, but we've got, I'm confident that we'll be able to manage your pain, or we've got lots of medication that we can use to make sure that you're comfortable when that time comes. We can take a few moments to just make sure that we're addressing that patient's fears about them coming to the end of their life. And all the time what we're doing at the moment is telling them that we're going to do positive things for them. We're going to keep them comfortable. We're going to make sure that they've got dignity, that they're comfortable with the right people around them in the right place. We're going to tell them about all these positive things. And as by doing that, what we're also going to be doing is affirming that they're making a right choice here, that their desire to stay at home is a good one. This is a good thing. We're going to help support you in this because this is really important. Another phrase that I sometimes use is, look, it's really important that you've said this to me. I'm really pleased that you've told me about this because you're the most important person in all of this, and we want to get it right for you. So that's the next thing that I would say. And then at this point, I'm going to maybe link into the DNACPR form because I've got to fill that form in. So there's different ways that I might approach this, but one way might be that I'll talk about the form which is going to try and achieve all of these things that we've just been talking about. So I might say, look, what we're going to do is write all of these things down on a form so that everybody knows what your wishes are. So that if a doctor or nurse who hasn't met you before comes in and sees you and you're too poorly to tell us what you want, well, we've written all of this down. We call this form a do not attempt resuscitation form. And what it does, it protects you from having something like someone coming in to try to restart your heart. So I put it in the positive. I talk about how the form is good, it captures their wishes, it brings everybody onto the same page, it protects you from the wrong thing being done to you. There are different ways to phrase it and do it, and sometimes I explicitly have say what's on what the form's called. Sometimes I don't. Often, if I'm with a patient, I'll fill it in and I'll let them read what I've written and say, do you agree with what I've written? Based on our conversation, and most of the time patients will say, yes, I do agree with that. So I think overall then it's really not about trying to just get the form filled in, even though we feel like it is, but actually it's about trying to understand the background of that patient and their context, what's important to them, what their priorities are, and it's trying to help them understand your medical judgment by kind of both coming to the same point of view without having pushed it upon them. So what you've done is you've asked them to describe how they want to die, where they want to be, and actually by doing that you're bringing them onto the same page as to where you are as well. Now, it's really important, of course, to document this discussion. So it's one thing to fill the form in, but you actually need to document it as well in the patient notes. And the other thing to say is just a note about capacity. Of course, you would hopefully get a sense early on in this conversation as to whether or not this patient does have the capacity to even be engaged in this conversation, to be making such a decision. And I would just say that if you don't feel that the patient has got the capacity to engage in this conversation that you're having, then it's important to have a best interest discussion. And by that I mean talk to the care staff, talk to the relatives, and then your opinion as well. Document everybody that's involved in that discussion, and write it down and your reason why you're not discussing the resuscitation explicitly with the patient. So look, I hope that's been helpful. Do take care and good luck with your discussions.